Hello and welcome back to the Neurotransmitters, your podcast about everything related to clinical neurology. I'm your host, Dr. Michael Kentris, and today I am pleased to introduce our guest, Dr. Johanna Seiden, a vascular neurologist at Montefiore Medical Center in the Bronx. And I'm really happy that she's coming to talk to us today because this is a topic that I struggle with a lot as someone who has to frequently cover the inpatient neurology service. And that is the evaluation of stroke, in particular, cryptogenic stroke, in particular, thrombophilia, coagulability type issues. So, Johanna, thank you so much for coming in, and I am really looking forward to some knowledge to drop on us today.
Thanks for having me. Yeah, I'm excited to be here and kind of, talk about what to do in these tricky stroke workups.
So, cryptogenic stroke, right? It's a very mysterious sounding name. But what do we mean when we say cryptogenic?
Yeah, so cryptogenic stroke kind of means that it is any sort of stroke that we don't have a clear cause for. So a stroke that could be small vessel disease, could be large vessel disease, but we haven't figured out the clear etiology of it, despite a rather complete workup, which typically includes like an MRI of the brain, vessel imaging, an echo, some sort of cardiac monitoring, looking for stroke risk factors like hypertension, hyperlipidemia, diabetes, and all of that done without a clear etiology. And that's somewhat related to this concept that you might have heard of ESIS, or embolic stroke of undetermined source, which has a lot of overlap with cryptogenic stroke, but just means that the only difference is that it clearly looks embolic, but we haven't found where that stroke originates from, whether it's like atheroembolic or cardioembolic or embolic from some other source in the body.
And, I know there's been tons of trials, in particular about the ESUS phenomenon. Like, should we just anticoagulate these people and call it a day? And it seems like time after time, the answer is kind of like, probably not.
Yeah, it's really tricky. And I think the trials so far have been a little bit disappointing, the results of them anyway. But at this point, we're kind of still left with treating them for the most part with aspirin until we find that clear source.
Gotcha. Now, cryptogenic stroke in particular it's one of these very frustrating things, especially if we have someone maybe on the younger side, like late 40s, early 50s, maybe even younger in some of these very unusual cases. And like you said, they don't have the classic cerebrovascular risk factors. And we're like, well, why did this person have a stroke? And like you said, the cardiac monitoring that's been going on and all that jazz, everything's come back unremarkable, no etiology found. When do we dive deep into some of these more esoteric, unusual type entities?
Yeah. So, I think when something in the story just doesn't really make sense for an ischemic stroke in someone who, again, doesn't have those typical vascular risk factors, isn't the normal, typical age. So as you said, like someone who's a little bit younger. So, yeah, I think we start to look for these more esoteric diagnoses when certainly like an embolic appearing stroke has occurred in someone without these typical vascular risk factors, without not being the typical age. So as you said, like someone who's a little bit younger. And a lot of it is in the history, other medical problems, history of sort of like clotting in other areas. And that kind of, gets us into some of these specific etiologies. But we're kind of taking a very detailed sort of clotting, hypercoagulability history, finding if there's any like family history of this and kind of going from there.
So a lot of times I'm just thinking back to kind of my own practice to an extent, for better or worse. And a lot of the questions I'll ask, like history of different clotting events. So kind of like unprovoked clotting, like DVTs or pulmonary emboli, things like that. And then in particular in women, if there's a history of spontaneous miscarriages or other kinds of difficulty getting pregnant, things like that. And then kind of broadly speaking, symptoms of, usually I'm asking kind of symptoms of like autoimmune conditions like lupus. Is that enough? Or what else should I be asking about?
I think that's Right. So we're asking, like, does anyone in your family or have you had any history of clotting either in the extremities or in the brain, in other parts of the body? Asking about those history of like miscarriages. Sorry, I'm just looking at this really fast. So, from what I remember about the APLS, like obstetric criteria, it's like recurrent miscarriages. And I heard actually like this great podcast by Curbsiders interviewing Dr. Ariel Langer, who's a hematologist who does a lot with APLS, and they did a whole podcast on this, and she was saying, in someone who has had a lot of pregnancies, you want to kind of understand the workup, and have they had pregnancy loss in a row? Sorry, I can't hear you.
So an isolated miscarriage in and of itself, probably not enough to be a red flag. But like you were saying, this serial events or these recurrent events certainly raises a little more suspicion.
Early miscarriages before like 10 weeks. And then I think also having 3 sequential spontaneous abortions or prematurity due to vascular disease. Those are kind of the obstetric concern. So it's not really like I had 2 healthy births and then I had 1 miscarriage and then I went on to have multiple other ones. It's more like these continuous ones are very early.
The vascular events, would that be like HELP syndrome or eclampsia, preeclampsia, that kind of thing?
Yeah, exactly.
Okay, that makes sense. So, one of the things, especially when I don't find anything in the history, which I feel like is all too often, is we send all these hypercoagulability labs. And there's a lot of them. And I've heard a lot of commentary on them in the past where basically they were criticizing neurologists for ordering too many labs and not knowing what they're looking for, and probably guilty as charged. So how do we tailor this in? Should we be ordering kind of a panel, quote unquote, versus like kind of trying to be a little more surgically selective with single labs?
Yeah, it's a great question. And I feel like this is a product of like the dot phrase. And I think, as a resident and trainee, I had a dot phrase for hypercoagulable workup and it had everything in it. And as I've kind of gotten more advanced in training, I've kind of realized that a lot of the workup that I was sending was really not appropriate for arterial stroke. So again, we're talking about arterial stroke. If there's a PFO, that kind of changes things a little bit, maybe. I mean, there's not great evidence for that, but in an arterial stroke for this sort of hypercoagulable workup, we're sending very few labs. So we're sending APLS, we're sending JAK2, we're sending ADAM-TS13, and that's pretty much it. Those are, the ones in our institution that we routinely send. These other ones that, used to be in my dot phrase of like protein C and S and factor V Leiden and antithrombin, the prothrombin like G20, 210, all of that, homocysteine, those are really for venous infarcts. And I think those, even for venous infarcts, the evidence is pretty poor. So this goes back to like the fact that these inherited thrombophilias are present in the general population up to like 5% for factor V Leiden, and they really don't end up changing management even if they're positive. So I think that's like kind of what this all boils down to is, are we sending things that if positive would really change management? And if the answer is no, and then, I don't think that they're worth sending. So like right now, the American Heart Association, American Stroke Association doesn't support routine thrombophilia testing in patients. And there was a study by a group in Colorado that showed that 2 of 5 patients who underwent this thrombophilia testing had at least one positive test, but only 1 in 12 ended up having a change in management related to that test. This was mostly in young patients, and most of the patients who ended up having some sort of change in management, it was because of APLS. These tests also cost a huge amount of money, up to like $2,000 or $3,000. They're not always covered by insurance, and they're not recommended. There is some data that these sort of venous related thrombophilic states are associated with higher stroke risk, but stroke recurrence itself is not higher in those patients with thrombophilic states versus the general population. It's not really shown to make a difference. These patients would be on aspirin kind of regardless of whether the test is positive or not. So it's not going to change management. And I think, the caveat of all of this is that if there is like a paradoxical emboli from a venous thrombosis, some of these may become more appropriate, but even that is not clearly guided by evidence at this point. So, I think for me, when there is a venous thrombosis, venous event, I'm more likely to send these tests, but whether it ends up really changing things is, not entirely clear, because the PFO will probably end up being treated or kind of fixed whether or not these tests are positive.
Yeah, that makes
sense. In a
young
patient with no other risk factors.
And we might come back around to PFOs in a little bit, because I certainly have some questions on that one as well. But as far as anecdotally, again, I definitely have had people who come back like heterozygous for some of these gene mutations, and I'll send them to hematology for a second opinion. And they're like, yeah, aspirin's fine. And I'll be like, okay.
Yeah. Yeah.
And it happens all the time, especially when like you said, I get like those PAI mutations and things like that. I'm just like, I don't know what the heck this is. And it's like there's like a mildly increased risk, like you said, of venous usually, but I'm just like, well, does that change anything? Probably not that much.
Right.
So
it's like it's our curiosity, but it doesn't really make a difference for the patient.
No. And that's always the frustrating thing, especially when you do have these younger people who have a stroke for no apparent reason. And again, it's one of those things where like sometimes they maybe have like prediabetes and mild hypertension that's well controlled in meds. They're in their mid to late 40s. Is that enough? Like, do I need to keep looking? I don't know. Just painting that broad picture. What are your thoughts?
Yeah. I think in a young person with stroke, if we're going to blame it on vascular risk factors, they got to be like pretty severe.
Mm-hmm.
I think mild hypertension, mild hyperlipidemia, prediabetes, it's not a slam dunk for kind of athero as the cause to not at least look for these other etiologies. The frustrating thing is I think even at the end of all of this, we have to recognize that there are going to be like a third to a quarter of patients who end up still being cryptogenic. And if we look back at these patients 20, 30 years from now, I think, we're going to have answers to why many of these patients had strokes. This is still such an evolving field, but there are this proportion of patients who end up, with we don't know sort of situation, but they do deserve like as complete and appropriate a workup as we can do before we label them like that.
If it is kind of an ESUS looking picture, I know insurance can be tricky for some people, so you end up doing like a 2-week or however many weeks insurance will grant you, like a Zio patch or Holter monitor, or some sort of cardiac event monitor. Do you always send them back for like an implantable loop recorder?
If they, I think the implantable loop recorder is obviously so much more sensitive than a 2-week monitor, especially if that 2-week monitor is being done not directly after the event, but a month later, 2 months later when you see them in clinic. So if someone is willing and my suspicion is high enough for it being embolic appearing, then I would rather go for the loop recorder. But that's obviously not totally my decision. So, want to make a good case for it.
No, that's totally reasonable. And I know I've drifted off our primary topic here.
No, it's fine.
Getting back to kind of our coagulability. So you mentioned the antiphospholipid antibodies. So walk me through these. I know that they're kind of associated with things like lupus and so forth, but what is their significance, and why should I as a neurologist care about them?
Yeah, it's It's a good question. And I think APLS, these labs can be like really confusing, and interpreting them can also be really confusing. And luckily, we're not always doing this in isolation. We are lucky enough to usually have hematology colleagues helping us out. But basically, these antibodies and serologic tests that we're using are testing whether the patient's body has these antibodies that recognize clotting and kind of overactivate it. So, a lot of people have these inherent antibodies. Sorry, I don't like the way that I'm saying that. The antibodies are recognizing these bodies wanting to. Sorry, it's really hard to explain this. Yeah, so I think that the antibodies are being activated in patients who have this kind of clotting system that's being overactivated in the setting of a lot of inflammation. So there are 3 tests that we send: lupus anticoagulant, cardiolipin, and beta-2 glycoprotein. The lupus anticoagulant is really like when PTT is elevated and doesn't correct with the addition of fresh frozen plasma. This one is the most high risk for thrombosis, both arterial and venous, compared to the other 2 antiphospholipid antibodies. And we should keep in mind that this one is also affected by anticoagulation. So if a patient's already on AC, this can certainly be influenced by that. And, this is why we end up needing to recheck this lab about 12 weeks later to confirm that, to confirm the finding. Cardiolipin and beta-2 glycoprotein are both ELISA-based. The elevated cardiolipin is either an IgG or an IgM, anti-beta-2 glycoprotein as well, an IgG or an IgM, and they're both affected by inflammation. And we're looking at titers for these. So we're looking at a titer, I think the lower limit is 40, so greater than 40. And again, the titers mean something. So the higher the titer, the more the body is being overactivated by this. So we need 2 positive assays that are separated by 6 to 12 weeks. And the amount and which test is positive gives us kind of a spectrum of risk. So a high risk APLS finding would be a positive lupus anticoagulant plus either anticardiolipin or anti-beta-2 glycoprotein being positive, or neither. So having a positive lupus anticoagulant is the most concerning, and that would be a high risk. So you could also have double or triple positive. The low risk would be an isolated anticardiolipin antibody, an isolated beta-2 glycoprotein at like low to medium titers, and then having one of these very, very low titers is probably less likely to be APLS. So these are the lab findings, but we also have to have a clinical finding. So the Sapporo criteria requires the presence of both clinical and lab related. So the clinical findings, we kind of talked about this already, but it's the presence of some sort of thromboembolic event. So stroke obviously fits into that, or a pregnancy-related complication. So those are the clinical ones. Yeah, so management-wise, we want to treat these aggressively. So the data suggests using warfarin rather than DOACs. Multiple studies have shown that warfarin does better than DOACs. So usually we're doing warfarin with a typical INR goal of 2 to 3. There have been some studies asking whether like a higher INR goal is more is better, and they haven't shown positivity. Some people end up adding aspirin as well. I don't think there's really good evidence for that, although evidence of downsides of that are also like not super clear. So I think if someone is having like severe clotting events or clotting through anticoagulation, I think at that point that's what we're adding.
Gotcha.
But we're doing this like with hematology. Usually they're kind of helping guide the treatment based on how the degree of positivity of these tests and the clinical story.
That makes sense. Thank God for hematology.
Yeah.
I know, because I only get these labs on maybe one patient every 2 or 3 months. And every time I have to go back and flip open some resource to read about, like, what does this mean? What does that mean? And be like, should I be worried about this or not? Like you said, a lot of times I will get like a weekly positive anti-beta 2. And I'm just like, is that enough? Like, oh, I guess not. And it does. It's very frustrating sometimes just because, like you were saying with these criteria, the clinical criteria is like, well, a thromboembolic event. Obviously, if we're on the case, it's because they've had a stroke. Is that enough to meet the criteria in the presence of, let's say, medium titer antibodies?
Yeah. It's a great question. So I think one of these things is the pretest probability. So if this is a patient who doesn't have these classic vascular risk factors, is young, our pretest probability is already pretty high for these tests to be appropriate to send, where if you end up with a positive result, it's real. So I think that's why we're not sending these on every patient. We're not sending these on patients who have like a really good reason to be having strokes. So I think if it's a young patient who doesn't have any other clear reason for strokes, and we get these kind of middle of the road titers, sometimes we'll end up treating at that point, and sometimes we'll end up repeating the test, waiting to treat until we repeat the test. So how this has been explained to me is the tests are confirmatory, but if you're concerned that this patient is, in a like florid APLS crisis, that we're not going to wait until 12 weeks to start treating them. So it depends on the story, but I think those repeating the test at 12 weeks kind of tries to weed out a lot of this. And sometimes the test can be positive initially because of, the reason that the patient's in the hospital anyway. So both the cardiolipin and the beta 2 are affected by like inflammation in the body. So again, like a lot of patients in the hospital have some sort of inflammation going on. So if those are positive and then you repeat it and then it's normal, then probably that wasn't the cause in the first place.
Gotcha. And I don't know if you know the answer to this or not, but sometimes I wonder if we have one of these patients and they receive like IV thrombolytics, on initial presentation. Again, it's one of those things where like how valid, if we draw it during like even like a day or two later, is that going to affect any of these markers? And I don't know if that's something that's ever been studied. I imagine a data set, if it exists, is small.
I'm not sure of any specific studies about it, but the lupus anticoagulant I think would be the one that could be affected by this. I think it's still, worthwhile to have that initial draw after the patient is on some sort of blood thinning medication or received some sort of blood thinning medication. And then when you get your repeat, you have something to compare it to. But yeah, it's a good question. And I'm sure, we'll have data that supports that moving forward.
That makes sense. Now, the other two tests that you said that you routinely check for were the JAK2 and the Adams T?
Yeah, exactly. The Adam TS13, which if you don't routinely send this, it can be like, wait, I remember hearing about this lab like back in med school and I don't remember what this is. So
that is me, yes.
Just some background on that. So that is a test that we send when we're looking for TTP. So that's like a microangiopathy that results from some deficiency in this metalloprotease Adam TS13 that regulates von Willebrand factor, another blast from the past, and it cleaves the like really large von Willebrand factor and prevents spontaneous coagulation. So if you have an Adam TS13 deficiency, then you're not able to prevent spontaneous coagulation. You end up being hypercoagulable. So this is characterized by hypercoagulability, acute hemolytic anemia, thrombocytopenia, end organ damage, super high mortality, like up to 90% if it's not treated properly. And we all kind of learn this like pentad of symptoms of thrombocytopenia, hemolytic anemia, fever, neurologic, renal complications in patients. But, all 5 are present together only in like less than 10% of cases.
Mm.
There can be small and large artery infarcts in these patients. And I think what's the most interesting development in TTP research is that there's evidence of ADAMTS13 deficiency even when platelets are normal or not so abnormal. So that's super scary. And you can also have, so platelets and hemoglobin really being normal. So they can have like atypical neuro symptoms. They can have like some sort of cytopenia. They might not need to, but this, again, going back to like, does the test being positive change management? Absolutely, because these patients need plasma exchange and, we're avoiding this really high mortality rate. We tend to send this in patients who have sort of this cryptogenic stroke of unclear etiology. Certainly if there's low platelet levels or anemia, but even if there isn't. So, for example, I recently had a case of this 80-year-old woman who presented multiple times with these bilateral embolic showers. She kept having more events despite being on the typical stroke medications of aspirin, Lipitor. She had like a complete workup. She had vascular risk factors too, which made it really difficult. And we ended up placing a loop recorder, which wasn't showing any events. She kept stroking. They looked very embolic. And ultimately, after this sort of risk benefit discussion with family, we ended up starting empiric anticoagulation, which, as we talked about, is not evidence-based, but I didn't know what else to do. She kept having these strokes. She had normal platelets. And then she presented like a 4th time, again, with this, like, with altered mental status, had this teeny little cerebellar infarct, super small. And she had platelets of 148,000. We checked ADAMT, which is, 150,000 is like the lower. Yeah. So we checked and it was positive. And the mistake, I think, was that I hadn't checked after her 3rd stroke, after her 4th stroke. We weren't routinely doing this in our practice, but there have been, a bunch of at least 2 case series that have come out about TTP kind of presenting in this sort of atypical way, and because of this, we now are checking more routinely. So this patient, we stopped the Eliquis. She's just on aspirin. She's getting these therapeutic plasma exchanges. And, hopefully this is the end of her stroke journey with us. But it was just one of these cases where that positive result totally changes the course of her treatment. So it's worth sending.
No, that's fascinating. Yeah, it's definitely not one that I think of as often as I probably should. So I'll have to keep that in mind.
It's not in the guidelines. This is like not recommended by the Stroke Association, but it's I think there's going to be more coming out about it, and it's something to consider in some of these ESUS sort of patients.
And that's the challenging thing, because sometimes you think like, oh, someone comes in low platelets. Well, I imagine she was been on some antiplatelet medication for a period of time at this point. So you do start to like kind of second guess yourself, I would almost imagine. Like, is this a side effect of the medications I've been giving her? Is this something her body is doing? And yeah, it can be a real conundrum.
Yeah, totally. Yeah, I went back through her platelet levels through the years, because she started having strokes like 2 years ago. And for the most part, when she would come in, they were normal. But then during the course, they would dip down and then come back up. And I think when we see that in our inpatients, we kind of come up with lots of reasons why that could be happening.
Right. Like, oh, it's dilutional.
Yeah. All sorts of things. But I think that's also something to be aware of when you don't initially send it on a patient. It looks fine, and then someone starts to get thrombocytopenic. I think, that's also something that we can send later on during their course.
Now, this is probably my own ignorance speaking, but I tend to think of with like TTP, like the purpura, right? Like the big skin manifestations are the thing that come to mind. Do these patients tend to have those typical skin manifestations, or are they a little atypical on that front?
I think they tend to be, I think there's mixed
Mm-hmm.
findings, but I think the lack of that shouldn't make us not check it. I haven't seen any TTP stroke patients who have had that, but I really don't know like how often that is present.
Because I mean, yeah, you see someone with a big honking bruise somewhere on their body that's not traumatic, like that's going to raise some red flags. But
Right.
yeah, if it's not there, it's harder to say.
Right. And if it is there, these patients are getting like daily heparin injections, like
Right. Again,
other
right.
reasons
Explain it away. Yeah.
yeah, exactly.
Oh,
Exactly.
very
Yeah. So
challenging.
that's the story of Adam TS13. And I'm excited about these cases. I think, we've at our institution are kind of going back through our data to see how often we're getting these cases, and hopefully we'll write up like a case series about this. But I know that there has been one that's come out a couple years ago, and it really is our hematologists who have this in their hypercoagulable workup for the past couple years based on some of this data.
Excellent.
Yeah.
So, what other entities should we be thinking about as we go through this clotting landscape?
Yeah. So the other one that we often will send is JAK2. So it's like one of these myeloproliferative neoplasms, and it can be found in like 3% of the general population, but patients who have ischemic strokes are about 2.5 times more likely to have JAK2 positive, and the prevalence of it in like TIA and strokes, at least in one study, is about 11.4%, which is eightfold higher than those who don't have TIA or stroke. And remember, smokers have a higher risk of having this positive. So it seems to induce a prothrombotic state. We don't have like clearly elucidated pathogenesis for it. Most common presentation for strokes related to JAK2 are large artery occlusion, but we can also get strokes that look more embolic in nature. So we tend to send this certainly in the setting of like thrombocytosis above 450,000 or hemoglobin levels that are elevated. Again, and this is not recommended. This is not, guideline based, but we're also sending these in patients who don't have those specific findings, because again, it really will change management. These patients will have will get treatments that'll kind of thin out their blood, and that ends up being their course of stroke prevention. So this one, I don't think there's as much clear data on, but we've seen this in cases, and so like to be on the lookout, especially if they have these abnormal lab findings.
Gotcha.
And if they're smokers.
Right. And I tend to think, and again, my hematology is rusty, as we were saying before we started recording. I tend to sometimes think, is JAK2 also associated with things like polycythemia vera? Am I remembering that correctly?
Yes.
Okay.
Exactly. Yeah. So yeah, you're checking like the EPO level and whether or not the EPO level is positive or elevated or low, then it's polycythemia or it's primary. So yeah, we recently had a case of someone who, like a 60-year-old smoker, came in with cryptogenic sort of stroke, and he actually came in with this like erythrocytosis of unclear etiology. It turns out his JAK2 was negative, but he had very high hemoglobin levels and ended up getting these treatments throughout his course, and was a smoker. So higher risk, did end up needing these treatments as a result.
Gotcha. I tend to think of this, perhaps overly simplified, as a case where the medieval bloodletting is still applicable, but
it is. It totally is. That's so true. Yeah. And I guess the other big umbrella of this sort of hypercoagulable workup that we do is assessing for any sort of malignancy.
Mm.
In anyone with a cryptogenic stroke or embolic stroke, where we haven't yet found AFib, which is majority of the embolic stroke sort of patients, is I always like to ask first, are they up to date with cancer screening? So in females, have they gotten recent mammograms? They got, and in everyone, about colonoscopies. So I always ask that. I ask about like constitutional symptoms, so any recent weight loss, like hot flashes, unexplained fatigue, which I feel like everybody says yes to. But yeah, because like similar to this sort of Adam TS13, where stroke can be the first presentation of TTP, stroke can also be the first presentation of malignancy. So the risk of malignancy, or the risk of stroke rather, peaks about 1 month before the diagnosis of malignancy. In many cases, 15% of patients with malignancy will suffer from stroke. That's like 2 times higher risk than patients without malignancy. And it's not really clear whether the mechanism of this is directly from the tumor itself or coagulopathy or iatrogenic, but things that kind of clue us into this potentially being related to an underlying malignancy. We hear about this T sign or 3 territory signs, so seeing embolic appearing strokes in 3 different vascular territories, or both posterior, anterior, seeing unexplained weight loss, an elevated D dimer, which again is a lab that can often be elevated in our stroke patients, but being very elevated is something that clues us in increased CRP, also nonspecific anemia, low albumin. So if there's any sort of atypical features of the case, something that's making us think that perhaps this could be, and of course a history of smoking is another one too, but we do end up like checking a CT, chest, abdomen, pelvis, just to make sure we're not missing any like very clear lymphadenopathy or any solid tumor, because we have certainly seen that these tests end up showing something, and then we know the reason for the stroke in a lot of cases. Management wise, there is a lot of or some evidence that anticoagulation is better than aspirin for these patients. Initially, it was like kind of modest evidence of parenteral AC, so heparin or Lovenox being the treatment of choice. There was some concern of increased bleeding risk, and there's some, obviously it's inconvenient for patients. There's some decent evidence that DOACs are appropriate for preventing venous thromboembolism in patients with cancer. There's more of an evidence gap for arterial clots. So I think a lot of us have shifted from saying Lovenox to using DOACs now, but the caveat is that there is not clear evidence from an arterial standpoint, but it has been supported from a venous standpoint.
Gotcha. And I tend to think, just to clarify, in my mind, I tend to associate the hypercoagulable state more with people who are with like kind of more diffuse metastatic cancer rather than someone with like a focally invasive cancer. Is that typical, or can you still see that hypercoagulability creeping up with someone who maybe has like, say, a grade 1 or grade 2 kind of like lung cancer or something like that?
Yeah. That I think, obviously the more metabolically active cancers, I think, have a higher risk of hypercoagulability and stroke, but I think we can see them in just like solid tumors too. So yeah, so worth checking. Again, this is kind of like looking for uncovering the reason for stroke, but certainly we see a lot of patients who have underlying cancer that is being treated coming in with stroke too. So, we're not always unmasking this. Sometimes, it's being given as the clear etiology.
Of an ongoing disease.
Yeah, exactly.
Now, just to add a wrinkle there, if I may, because as you were mentioning, right, is it the cancer? Is it a result of the treatment? And especially with the way that a lot of chemotherapy is evolving these days with some of the checkpoint inhibitors and the CAR T modulating and all that kind of jazz, we're starting to see a lot of these unusual neurologic symptoms. Has that been showing up? I know on the general neurology side of thing, I've been seeing cases like autoimmune induced, or I should say, like checkpoint inhibitor induced, like myasthenia, Guillain-Barré, stuff like that. Are we seeing similar entities evolving in the stroke field as well?
So I definitely haven't seen as many of these cases as I did when, as a resident. I think there are like one or two cases where someone's on a particular agent, and we end up finding a few case reports that are supporting that strokes can be due to these medications. I think more frequently we end up kind of attributing it to just a general hypercoagulability and not the treatment specifically.
Yeah.
But I don't think we know.
Yeah, I mean, unless, as you said, I think I've seen maybe one or two cases in the last handful of years where someone was on like bevacizumab for, I forget what kind of cancer they were getting treatment for, but right, one of those vascular endothelial growth factor inhibitors, which we know can do like, vascular injury, like with heart attack, stroke, things like that. So in that particular case, I had recommended maybe not using that for future treatments if possible, but it does become a little bit of a rock and a hard place in terms of, someone with, usually if they're using something like that, a fairly aggressive cancer versus the risk of further vascular injury.
Yeah, it can be really challenging. We usually try to speak to the oncologist and kind of asking them in their experience, have they seen other patients who've had this sort of event on this medication? And we're kind of coming from two different places, but I agree that taking someone off of a medication, especially if it's helping because of this question of maybe it being the cause, I would say we don't often feel that is the best way forward. I think we more often we tend to just recommend some sort of blood thinning medication to try to help decrease the coagulability in the patient.
Right. Definitely a risk versus benefit.
Yes.
No clear answers in those situations, usually, I'd say.
Yes. And, that also, to add even another wrinkle onto this, definitely had patients come in who are already on a blood thinning medication for the cancer, come in with another embolic appearing stroke. And, there's the team will ask, well, should we switch the blood thinner to another blood thinning medication? Maybe they're stroking through Lovenox, but should we do, Eliquis? And we don't have the answer for that. I don't think the suspicion is high enough that the problem is the specific anticoagulant. I think it's that, perhaps the underlying coagulability is just too high at that point. So yeah, they can be really, really sad, tough cases for patients who are already dealing with so much.
I don't know if you're a Star Trek nerd like I am, but I remember this one line from Captain Picard where he was saying, like, you can still do everything right and still lose.
Yeah.
Which, it's on the one part, you can be proud of what you have done, the work you have done, and not be ashamed of anything, but know that the outcome may still not be optimal. So
totally. I feel like I don't know that quote directly, but I feel like that sentiment I am constantly saying to myself. I think, all of us are trying to help patients who are coming to us already with some issue, and we're trying to do the best that we can to take that issue away. And especially I think in stroke, where patients are coming in, very sick and very far gone at times from stroke. And, we're trying to give them a chance at getting those symptoms reversed. And I think the most painful thing that I deal with is when I decide, that a patient is not a good thrombectomy candidate for whatever reason. I think that's the most painful part of the job, because the stroke is too far gone at that point. They have, other reasons why they're not a good candidate. I think that's where I end up doing a lot of self-talk that we're trying to, we're trying to do what's best for the patient, but it can be really painful when you feel like, you couldn't do everything.
Right. Yeah. Sometimes certain options just aren't on the table. I think we've all been in that situation where it's just like, if only they'd been here a few hours earlier. Right.
Yeah, exactly.
And you're just like, yeah, it really frustrates everybody involved. I think that's just an unfortunate nature of our current treatment paradigms.
Right.
It's what we've got.
Yeah. We all came into this profession trying to do the most to help people. And I think it's such an unnatural and bad position when we feel like all the tools that we have are like not enough to help that person.
I think in that situation, it's sometimes good. I think a great example of this is like multiple sclerosis, where in the 90s, before the early to mid 90s, there was nothing, right? And so it was just a question of like, how long is it going to be until this person is in a wheelchair or disabled in some fashion? And, I think stroke in a lot of ways is also mirroring that. Like just in the last decade, there have been so many advancements in terms of interventions available and things like that. I mean, still obviously very front loaded on the acute side, but as we've been talking about today, still looking very much into the back end of things and trying to, right, prevention always of the utmost importance.
Yeah, definitely. Definitely. Yeah, stroke they used to say it was diagnose and adios.
Right.
And now there's a lot we can do, not everything, but a lot we can do to try to reverse the symptoms, which is, I think, why it's so rewarding is because you can see someone with a huge infarct or a huge potential for infarct that have come in with a lot of symptoms, and then that clot is taken out and they end up walking out of the hospital the next day or the day after. So, that's like the most, those are the best cases. I wish those were a little bit more often, but.
So what other entities do we need to think about in these cases in terms of, clotting disorders or things that might prompt us down a different treatment pathway for some of these people without the typical risk factor profile?
Yeah. So I think this is most of like the hypercoagulable sort of workup. Another area which isn't really what we're focusing on today, but I think is worth mentioning is this always comes up of like when to look further in the heart with a TEE rather than a T. When is that gonna be helpful?
Mm-hmm.
And I think in many of, especially in these young patients with embolic appearing infarcts, we do end up wanting to look for like a cardiac tumor. We do want to, make sure that we're ruling out a large PFO. So, and then, if there's any concern for infection, fever, we want to make sure that we're ruling out endocarditis too. So a lot of these like cardiac tumors, like cardiac myxoma, fibroelastoma, those are better visualized using a TEE. In general, the TEE is better than the TTE for looking at like the ascending aorta, for looking at the aortic arch, the left atrium, an atrial septal aneurysm. Endocarditis, we can often see more clearly evidence of clots in using a TEE. And then for PFO, a TEE gives us a better view of the septum. So that can be that's a better test. So, if the suspicion is high enough and the patient is young enough, doesn't have those other vascular risk factors, then I think it is worth it to try to get our cardiology colleagues to okay a TEE, which can vary by institution and how easy it is to do that. Often if we end up saying like PFO or endocarditis, those are the magic words.
Mm-hmm. Yeah, I know that getting that TEE, especially like in the hospital in the acute stages, can be challenging logistically. They may only do it on certain days of the week. So you're waiting, like, do I keep this patient who's otherwise like ambulatory and ready to go in the hospital for another 5+ days if they come in just after the window for when they do the procedure or what have you, especially at a smaller hospital? That can be a hard sell, at least from a financial standpoint to everyone involved.
Yeah,
so definitely. I know that, like you said, sometimes you have to coordinate with your colleagues in the other departments and get something expedited on the outpatient side sometimes.
Right.
But yes.
And I guess just, while we're mentioning PFO, because I feel like it's a hot topic.
It is a hot topic.
So when we're concerned about PFO, as you know, like PFOs are present in like a quarter of the population. So the question is not really if a PFO exists in this patient, but is the PFO itself the cause of the stroke? So there are a couple like scoring systems that have been developed that kind of help us answer this question. One is the ROPE score. And so that's sort of asking the question, does this patient have another like better reason to have stroke than a potential PFO if we were to find it? So it's taking into account patient's age, the presence of these vascular risk factors, the presence of the stroke, which, everyone would have a point for that. But even then, that might not be specific enough. So the Pascal score or criteria adds in these added factors of how are there high risk features of the PFO. So is the PFO itself large? Is there presence of like an atrial septal aneurysm? Those increase the risk of the PFO being pathogenic and being the cause of that stroke. So, a lot of the time we'll get an echo report that says like small PFO. If that's on a TTE, then sometimes that's enough indication to move forward with a TEE to better evaluate it. If it again, rates the PFO as small, just like a couple bubbles, no atrial septal aneurysm, that patient, the likelihood that patient has a stroke related to that go down a bit. So in someone who doesn't have other reasons to have a stroke, doesn't have hypertension, hyperlipidemia, diabetes, doesn't have like carotid disease, has a large PFO with high risk features, that is the sort of patient that we think about closing the PFO in. So typically we don't even look for a PFO in patients who are generally older than 60 or 65. Because if we were to find it, it generally won't change management. The reason why the PFO, why it's not as easy a question of just close the PFO is because closing the PFO itself is a very risky procedure and actually like has a pretty large risk of causing atrial fibrillation and potentially causing another stroke. So this whole risk benefit balance becomes very, very important in these PFO conversations.
Yeah, I know we have a structural cardiologist in the area, and I say that because there aren't that many in our area. And I'll get referrals from him where someone maybe had a small stroke, they found an incidental PFO, and they send it to like, hey, do you think this was causative? And like you said, you kind of have to go through, calculating the ROPE score of like, nah, it's like, or like the MRI characteristics. It's a small thalamic lacunar infarct. Probably not. In the 20-year smoker with high blood pressure and diabetes. But it is one of those things where I certainly appreciate the thought that goes into asking that question as opposed to, as you said, just kind of closing the PFO. Yeah,
for sure. That's very considerate of the cardiologist to reach out, because I also feel like many don't. Yeah.
Sometimes you have colleagues that don't communicate as well as you would like, and I'm fortunate at having the ones that I do who do.
Yeah.
I do wonder. So let's say if I can hypotheticalize for a moment, if we have, let's say, a younger person, late 40s, early 50s, again, kind of similar to the earlier one, like kind of mild hypertension, maybe sleep apnea that's untreated, and a little bit of prediabetes, has what looks like, in an ESUS category, embolic stroke of some kind. Initial echo was negative, and initial, like the transthoracic, and then the 2-week monitor was also negative for AFib. Are you going to be, these patients probably should be going for both a TEE and a loop recorder. Would that be accurate?
Yeah. I mean, I would definitely do the TEE on that patient. The loop recorder, I mean, I think the likelihood of like a 40-year-old having AFib is pretty low. So I think that would probably be the last test I would like really talk to the patient and see if that's something that they want. Some patients really want to have all of their I's dotted and all their T's crossed and are not comfortable unless we do that.
Right.
I think other people are also very put off by something going under their skin and kind of staying there. And the truth is that many people end up getting an ILR and then it's never removed. But I think the TEE is much more potentially, much more of an important test for that sort of patient.
No, that makes a lot of sense. And certainly, I think this conversation today it was very beneficial for me and hopefully for our listeners as well. We tend to, for us non-vascular neurologists, to think, oh, stroke, boring. But it is, right? As you were saying, this is a significant minority of patients presenting with stroke, probably the most common inpatient neurologic entity that we deal with. And it's not always just plug and chug as far as we follow the algorithm and aspirin, Plavix, statin, see you in a month in the clinic.
Yeah, right.
So there are a lot of these cases where it does require that critical thinking to say, does this make sense? Do I have an explanation? And when I'm working with residents, a lot of times I'm asking that question, does that make sense? And that's really, I think, the problem is that it's easy for us to take the easy way out so that we don't have to think as hard about things. We're like, oh, well, they got a little bit of hypertension, a little bit of diabetes, and they come with this, branch M2 occlusion or something like that. I'm like, well, is that enough? I don't know. And so you always wonder, right? You're trying to strike that balance between, cost to the patient, testing the patient has to go through versus do I have a sufficient explanation to make sure that they aren't at high risk of a recurrent event. And that is always a challenge in some of those cases where you don't have the smoking gun, as it were.
Totally. Yeah, absolutely. This brings up a case that has been really making me lose sleep the past couple weeks again, like 40-something-year-old has very, very mild hypertension. She's not overweight. There's no evidence of metabolic syndrome. And she came in with these very bad headaches. She has a history of psoriatic arthritis. She's on methotrexate and leflunomide. And came in with this very bad headache. She has a right M stenosis, luckily no stroke, and ended up having a very, very extensive stroke sort of workup to figure out why she had this M1 stenosis. She ended up having a diagnostic angiogram that showed multifocal vasculopathy versus vasculitis. This also a dreaded conundrum of is it vasculitis? This could be a whole podcast for another day. They'll probably end up being multiple days long. But I saw intracranial stenosis in different vascular territories. She has a little bit of hypertension. Her LDL was 100. So, my first thought was, oh, yeah, she probably has ICAD. Let's just do aspirin Plavix for 3 months and we'll see her in clinic. And then, something doesn't feel right. Something doesn't feel right. Can I really just say this 40-year-old with really no clear vascular risk factors has ICAD? She has this sort of rheumatologic kind of background. We had rheum involved to try to see, is it methotrexate be the cause? Does this patient have other indication of increased inflammation in the body? Kind of all of those labs were negative, the ANA, the ENA, the LP was fine. And so, now we're going down this whole rabbit hole of a primary CNS vasculitis because, it doesn't make sense. Mm-hmm. When we really think about it, this patient having ICAD doesn't make sense. She's not the typical patient for it. So I think, as exhaustive and extensive of a medication course for possible vasculitis it's because that thing doesn't really fit. Yeah. It doesn't make sense to chalk it up to something that is just not typical in that sort of patient.
So did you pull the trigger?
Yep.
Steroids, rituximab,
steroid course, Cellcept. Yeah.
Nice.
The whole thing. It even though it's way more for the patient, it feels like that's what needs to be done.
Mm-hmm. Yeah, I know. I had an attending, she was a retired military person, and I would ask her how did you, because she would, she was a little more bold than some of my other attendings, and she would just say sometimes, Mike, you just need to put on your big boy pants and do it. And she's pretty much right. It's true. this is something that I observe a lot in medicine at large, where you get people saying they're not quote unquote comfortable doing something. I'm like, guess what? I'm not comfortable doing a lot of things, but sometimes it's the right thing to do, like being the one to make a decision, on a potentially life-altering medication like thrombolytics day after day. Some days might feel a little uncomfortable, but that is the decision. That is a role we have signed up for, and we have to own that responsibility. So yes, unfortunately, being a physician in medicine means you have to make decisions that will make you uncomfortable. And so that's just one of my pet peeves in medicine. People saying they're not comfortable with things.
Yeah, no, it's true. It's true. And I think like we have all seen cases that made decisions on cases that, and then we sit with that decision and it feels like, I don't know, like, not getting that extra imaging, not getting vessel imaging up front, something like that. And then,
right.
Often it kind of sits with you and you're questioning. You can always, modify your plan. This comes up a lot, at least with our stroke fellows, that, they'll make a decision. They'll say, I don't think we need X or Y. We don't need vessel imaging. I don't think this is a potential treatment case. Doesn't sound like a large vessel occlusion. And then we change it and we say, you know what, let's get the vessel imaging. And it ends up being something that we need to treat. So I think it's also, don't be afraid to kind of trust your gut telling you that something doesn't feel right about the decision you made. Usually there's time to go back and change course.
Yes. No, absolutely true. Any final thoughts that you have on this particular topic for our listeners today?
Yeah, I mean, I think kind of piecing it all together, when we're thinking about hypercoagulable conditions and stroke, we're thinking about those tests that would really change our management. So we talked about APLS, we talked about JAK2, we talked about ADAM-TS13, we talked about potential malignancy. I think, one more area that we didn't really discuss, which is maybe worth mentioning, is sickle cell disease.
Oh, yeah.
Especially, this is more for pediatric population, because for adults, majority of the time, a patient knows that they have sickle cell disease, comes in with a stroke, and, we can kind of figure out that stroke is due to sickle cell disease. But in pediatrics, I think, they haven't always presented yet with symptoms. And most of patients are screened, have some sort of hemoglobinopathy screening at when they're newborns or as in their routine anemia screening. But especially if you work at an institution where you get a lot of patients coming from other countries or may have not been, not gotten proper care, something might have fallen through the cracks, we do tend to think about that in pediatric strokes, because as we know, sickle cell disease is a very common cause of stroke. A quarter of patients with it will have a stroke by age 45. And so at least in the peds population, there's clear guidelines about screening kids from 2 to 16 with yearly transcranial Dopplers, planning for transfusion therapies to get the hemoglobin S down to less than 30%. That's been shown with trials to reduce the risk of stroke in those with elevated risks. It's not really clear whether adults have the same untreated risk or whether they benefit from that treatment. So there is this gap where patients are no longer with a pediatric hematologist with sickle cell disease and don't continue to get this sort of screening. Sometimes we'll end up seeing patients who have stroke related to sickle cell disease, and so they haven't gotten that sort of, yearly TCDs. But I think these patients are very, high risk for stroke from this kind of atypical mechanism. So I think it's reasonable to screen for sickle cell in any patient, adult patient with anemia, any who have stroke, especially if there's evidence of moya disease. We see that a lot. And then certainly in pediatric population, we want to consider that, because there's clear there's clear management decisions that come after patients with sickle cell have stroke. So if they present with stroke, we're like immediately doing exchange transfusions. The question about using TNK or thrombectomy, there evidence for using TNK or TPA. The recommendation class is A, and there's not great evidence. So it can be beneficial, but we don't have great evidence for it. And then there really aren't clear guidelines on thrombectomy. But, we, especially like in the Bronx, we see sort of patient a lot. And even last year, we ended up doing a thrombectomy. We were talking before on a patient who, a 3-year-old who came in with like a left ACA and an M1 occlusion and sickle cell disease. So she ended up getting prompt exchange transfusion and going for thrombectomy and having a pretty good recovery, all things considered. So these patients do come up, and it's just important to be aware of the link between sickle cell disease and stroke, especially if you're practicing in an area where you have a pretty sizable sickle cell population.
Oh, great point. Very challenging when we get into some of these disease entities where we just don't have the data to guide us as robustly as we would like, especially when we have more aggressive treatments for the general kind of population, as it were. But yeah, just kind of cross apply and do the best you can.
Definitely. And another area where having open communication with the hematology team is super important, because as quickly as we want to get these patients in the scanner, give them these potential treatments, they need to get the exchange transfusion as soon as possible on their end too. So we're kind of juggling multiple things. And then, once they leave the hospital, they obviously are continuing to follow with the hematologist. If they're kids, they're getting these regularly scheduled transfusion therapies. Sometimes they're getting hydroxyurea. They're getting these yearly TCDs. So they need to be really hooked up into the system.
Yeah. It can be a lot to take on, especially for a child.
Yeah, definitely.
Well, I've certainly learned a lot. I've been jotting down notes for things I need to institute into my own practice as we've been talking today. And I hope others will be doing the same as they listen. So thank you again to Dr. Johanna Seiden. If people want to find you or contact you, if you want them to, where should they look for you online?
Yeah, that would be great. So I am on X/Twitter, at least for the time being, at Johanna Seiden MD. So yeah, reach out to me via that. I try to post some little schematics to try to make stroke education a little bit more clear. So yeah, if there's any questions anyone has or any clarification from this, I'm more than happy to chat. Yes,
those have been some great infographics that I've been enjoying as well.
Thank you.
And you can, of course, find me also on Twix as well. I'm at Dr. Kentris, DrKentris. And you can, of course, find the rest of our stuff at theneurotransmitters.com. Johanna, thank you again so much. I really appreciate you taking the time today.
Thanks, Michael. Such a pleasure.
Take care.
Bye.